Hello, I'm Dr. Russell Libby, and I welcome you to the world of medicine. You know, we're going through a huge reorganization of healthcare in this country. And what we've been focusing primarily on are politics, appropriations, and maybe a little bit about insurance. But we really haven't started to focus on some of the real key issues, and those are healthcare and healthcare delivery. One of the issues that is of great significance to me, a very important one, is mental health issues in children. Now, when you think about the variety of things that affect children and their mental health, starting in infancy, even before birth for that matter, going through childhood, through adolescence, into young adulthood, into adulthood, it has significant impact on our healthcare dollars, on our country's productivity, and of course on everyone's quality of life. These are issues that we need to understand better. What is anxiety? Well, we know we think about anxiety in its generic terms, but really, how do we know when it's a problem? Depression, suicide, substance abuse, alcohol, all these sorts of things affect kids in a very different way than they do adults, but they carry into adulthood in a very significant way. Today we're going to talk about a lot of the things that affect kids and their mental health. We have with us a faculty from one of our really a gift to our county from INOVA Health Systems, the Keller Center. It's a wonderful place with a variety of programs we're going to hear about. And we're here with some of their staff. Dr. Sonia Thomas, she's a psychiatrist. Dr. Tozzi, she is a psychologist, a clinical psychologist. We're going to hear about what the differences are there. Dr. Lorency, Fernando, who is also a psychiatrist and dealing with kids, and Dr. Leichtweis, who is the executive director of the Keller Center. So when we talk about the Keller Center, we need a brief overview. We're going to talk about the programs as we go through the show, but tell us a little bit about how it came about and what kinds of services we see there.
Well, thank you for having us today. This is really a great opportunity for us to share with you and the community about the great services that we do. The INOVA Kellar Center was established in 1991. It was founded in 1991 as a partnership between INOVA Health System and Art and Betty Keller, who were members of our community, a businessman and his wife within our community, who were very supportive of mental health and substance abuse services because of some personal issues that they had had within their own family that they were very open about. And that partnership, through that partnership, we identified that there were some significant gaps in services in Fairfax County and now the region. Those services really included substance abuse treatment on an outpatient basis and mental health treatment on an outpatient basis. We have wonderful wealth of services in this area, yet the need really was overweighing the available services that were available, particularly through the public sector. So through the support of the Keller family and the Keller Family Foundation, we were able to develop a program that started pretty small as a partial program, an after-school program that provided support to kids. It was our first mental health IOP program. And we expanded that over the years, where now we have a full continuum of services from individual therapy once a week, therapy med management, psychiatric evaluation, all the way up through intensive outpatient programs, after-school programs for several hours, and even a partial hospitalization program where our children come for the entire day and stay for several weeks with us throughout the course of the treatment. In addition, we were able and quite fortunate to be able to establish the Keller School, which serves children who are identified through our educational process as children in need of special education due to an emotional disability or a learning disability that's interfering with their ability to be successful in a public school setting. And so we contract with 7 jurisdictions in the region to support them in educating these children. It's really a wonderful program.
So it's a pretty full spectrum of services, and believe me, as a pediatrician, I know it's very difficult to access the right kinds of services and to feel confident you're getting good care for your patients, especially when they are significantly dealing with a terrible, terrible kind of problem. When I think of the kinds of things that are affecting our kids, I guess one of the areas that or one of the diagnoses that I think is so ubiquitous, it's everywhere, is anxiety. I find, I see parents in the first year of life and their children start to demonstrate early on stranger anxiety. They're 6, 7, 8 months old, and strangers walk into the room and the kids just light up with screaming. That's anxiety, but anxiety has a pretty full spectrum that goes through childhood and through the lifetime. Dr. Fernando, you're pretty expert on these anxiety issues. Tell us a little bit about anxiety in the first year of life, how that is normal and where it sort of deters and becomes abnormal.
Well, to start out, there are normal fears that developmentally at different ages kids have. As you said, 4 to 8 months, stranger anxiety, noise are things that kids are fearful about. As they grow older, 1 to 3 years, again, stranger, separation anxiety, darkness, a little older, monsters, fears for supernatural things. Separation anxiety is big in that age group. But a little older than that, elementary school kids, fears about, physical well-being, fears about how the social group treats them, teases them, bullies them, but also about natural events. Elementary school age group, that is pretty normal. And then in adolescence, a lot of fears about psychological well-being. Am I normal? Do I think normally? Again, how the peer group accepts them or not. So these are all normal developmental fears that kids have. And as what we are looking for, even as kids grow older, is how do we separate normal fears from a budding anxiety disorder? And usually pediatricians are the first people who pick that up, or parents call them about a child who's crying too much or has a lot of difficulty consoling. So that's exactly what we are looking for. Is the distress too much? Is it persistent? Does it last too long? Is the intensity too much? And does it start to affect other things? How is the family doing with this? Is the child refusing to go to bed alone? Is the child refusing to separate, not just on little 1 or 2 occasions, but at all levels? Not going to sleep, not wanting to go to a camp, not wanting to go for a sleepover with a friend, which all along they were doing, and then difficulty with going to school. So we're basically looking to see, is the symptom too much, and what else is causing impairment, functionally, how is the child doing? And so these are all different things that we are looking for, to differentiate what is normal versus what can be pathological. But, pediatricians are the first people who usually hear about this.
Well, I think of it in my practice. So we're saying that, babies have stranger anxiety. It's hard to attach a diagnosis of anxiety disorder to that.
Yes.
I think that probably the parents have more anxiety disorder about that stranger anxiety that
Sure.
kids have. And that ends up being more of a panic issue than actually the kid's condition that way. But I think about the child who's going into preschool, who's very talkative and very active and very happy at home, and then they go to preschool or they go to daycare and they're completely quiet. They really do hole up. They may cry inconsolably when they're dropped off. Give us a little perspective on when you have kids who are real quiet, kids who don't want to interact except maybe in the comfort and safety of their own environment.
Sure.
But the kinds of signs that we look for in young kids relative to anxiety.
This is when we are thinking about predisposing. What causes, who is the kid who presents with symptoms that are intolerable, So that is when we look at family history. lot of anxiety in the family, genetic load we call, So if there is a lot of anxiety in the family, we look at that. Then if there is mood disorders, that also can cause anxiety disorders in other people in the family. The other piece is just the temperament of the child, as you said, shy, kids who are shy, who are timid, who are slow to warm up. That is one issue that 20% of the kids who eventually present with anxiety disorders are temperamentally like that. And then parenting style, how parents parent a child who is any sort of temperament, if they're highly critical, if they are very judgmental, and if they push the kid beyond what a child who is shy or withdrawn can do, So these are all things that we kind of keep in mind. Attachment issues. How secure was the attachment from 0 to before they entered elementary school? So, but in terms of symptoms, usually fears, these fears are excessive. Crying is there. They have difficulty with separation. Sometimes they have nightmares that is related to the theme of separation. Then a lot of times they have somatic symptoms. They have stomach aches, they have headaches, there is nausea, gastrointestinal symptoms, headache, neurological symptoms. So all these other extra factors can be present, but that is what leads parents to be worried. The school calls them, the child daycare calls them, and that's when parents kind of start to notice that the child is not sleeping in their bed, is more fearful now, of the dark, of the monsters, all these fears that are developmentally normal, but they take on a different kind of a twist. So those are the symptoms to essentially look out for.
And when I think about anxiety disorder, of course, you have that whole gamut of different types, but I see kids who don't want to go to school.
Yes.
They worry excessively. They're constantly asking about someone's health, or there are different types of anxiety-based disorders. And I guess you probably do a fair amount of investigating, looking at these kids. At what age do you start doing any kind of assessments from a psychological point of view relative to what are the testing you can do? Do you do the testing for anxiety and other kinds of mood disorders?
Personally, I have in the past. I do not at the Keller Center. I pick them up when they come in as adolescents. But in terms of testing for anxiety, you can start quite young, absolutely. And some people even start doing psychological assessments with infants, to start to screen for any kind of abnormalities, with anxiety, especially with, developmental type delays and issues. And the testing is different depending on the age of the child, but certainly if you are concerned, psychological assessment or a psychiatric evaluation would be,
Okay.
Good ways to screen.
So the testing that you do in the more sort of classic standardized approach would come at a later time when the kids can more interact, as opposed to the psychiatrist who's going to do more of the observational and historical sorts of things.
Mm-hmm.
Just to stay on the subject of anxiety, because I like to keep it all packaged together. Now, we have a number of different types of anxiety that people identify. Certainly there's that generalized anxiety, which I think we were sort of talking about along with the separation issues, which is just sort of worrying about things excessively to the point where they inhibit your ability to basically enjoy your routines and your normal activities that should bring you pleasure.
Yes.
We also see kids who really develop incredible fears of specific things.
There are specific phobias.
Phobias. So tell us a little bit about when we start to see phobias and when is it severe enough? I mean, kids get upset about insects and they may not want to go outside today, but it doesn't get in the way. But tell us a little bit about phobias and how those things happen.
Most of the time, later middle school is when we really start to get concerned about these things. Insects, animals, kids usually are afraid of them. But it's later 9+ years of age is when we actually start to see phobias develop. And again, they come to us and we do a psychiatric evaluation and end up with a diagnosis. And most of the time we start with the therapy approach, cognitive behavioral therapy is what we will recommend at that point. But again, it has to be severe, it has to be persistent, and it has to impact functioning. So yeah, phobias are one, separation anxiety disorders are another, generalized anxiety disorders is something we frequently see. We see a lot of that with our day treatment population, 12 plus years of age. School refusal is a big piece. Dr. Thomas and I and Dr. Tozzi work a lot with our school refusal kids. But even as we evaluate, there is a lot of, usually there is either generalized anxiety or a lot of social anxiety. But sometimes there is comorbid, mood disorders present. But most of the time it's around that age group, 12 plus, middle school years is when we actually start to see a lot of school phobias,
Right.
And that is pretty much there in the community. We work a lot with those kinds of kids, and we're pretty successful in getting them back to school. Actually, at least that's what I feel.
So it's the partial hospitalization has almost a track for helping these kids out.
I wanted to get back to your original question around when these children enter preschool, kindergarten, and they go to school and they're different than they are at home. And I think that we see a lot of that, whether it's that transition into preschool or elementary school or middle school, or from middle school to high school, and even high school to college, we see a natural change in our children's behavior. I mean, that's typical. And I think that one of the things that's important in what we do accomplish, particularly with the younger children, is it isn't any one thing that's going to say this is it. It's that whole biopsychosocial approach and the techniques that are used in assessing that child. And oftentimes a child will come in a young child will come in with those types of symptoms or problems, and through some play therapy, we find we get a lot of information, and they have a few sessions, and we do some work around parenting skills and just calming the parental fears of the change in behavior. There are a lot of children in this world who go to school and are different at school than they are at home. And that's, for them, that's their normal realm that they live in. So I think it's really important for parents not to overreact. And I think that's one of the things that good mental health treatment can provide is what's normal and typical and developmentally appropriate and what isn't. And it's when through that process that you identify this is outside that realm, and that's when we start getting concerned at that younger age. With the older kids, it's a little easier because they're not going to school, and that's you can actually identify the behavior.
So it's a palpable behavior at some point.
Exactly.
And it's interesting that you say that because I think a lot of parents do have a hard time being able to overcome and to actually understand the reactions in their child if they aren't standard and predictable the way they would like to see them. Of course, a lot of them being biological, they never necessarily were able to deal with their own anxiety, or they've been in therapy for years and treating them themselves. But they really do have a hard time knowing how to intervene because nobody did effectively do that with them. So really, if they come to me with the child, if I can sense what's going on, I'll often give them that help. But so you're saying with the young child, you do some play therapy, which may or may not be productive. But the main thing is, as I understand from what you say, is dealing with the parents.
Yes.
And getting the story from them, helping them understand what the origins, what the symptoms, and really how to respond and react when they get frustrated and they don't know what to do.
Yes.
So it's
And a
parent
lot
training.
of parent training, and essentially for anxiety, support and reassurance for the child is the key, and that is something that parents have to be taught, I feel, a lot of times, because the principles of behavior, a lot of times it is taking away things, punishing. And when a child is fearful about something, taking away things or punishing or criticizing them is something that absolutely will not work. So a lot of reassurance and support is what will help the most. And a lot of parents appreciate just knowing that that's all they need to do. That's easy to do, is what they will say. But yes, a lot of parent training is key to before we recommend individual therapy or any other forms of treatment.
And a lot of times, because of the way parents react to one set of symptoms, they create other kinds of anxieties in children, and they don't always show them as being nervous. Sometimes they'll actually be aggressive. Sometimes they'll be verbally abusive even,
Yes.
and combative, but only with their parents.
Yes.
But their parents think that they have some other kind of abhorrent diagnosis,
Yes.
when actually it's the malinteraction that really generates
Yes.
the progression of the symptoms.
And a lot of times that's what we are looking for in our evaluation, where do we see these symptoms? Are these symptoms only at home, or do we also see it in other settings, like at school or at a church where they go for Sunday school? And so these are all parts of in the psychiatric evaluation, these are the things that we are looking for. But you're right, anxiety can present itself as crying, clingy, anger, any different ways, but a lot of times the presenting symptom when they come to us is anger and aggression, and we work with we listen to the history from the parents and we talk to the child, and what we find out is anxiety, and the parents were not even aware of that,
Right.
So that's that is what we find out in our evaluation, and based on that we talk to them about what needs to be done next.
And you're talking about kids going through childhood and adolescence, and at times they may have anxieties about things that they become really hyper-focused on, phobias as you describe them. And at some point they become so focused on them that they obsess about them.
Mm-hmm.
And of course, part of that spectrum is obsessive compulsive disorder.
Yes.
Sort of give us that transition as to how we understand what the difference between anxiety and becoming obsessive compulsive might be.
Sonia, do you want to talk about
OCD, obsessive compulsive disorder. Interestingly enough, people with OCD might have that, it's almost this thing of nature versus nurture. So you might have anxiety, and then kids in different families might express itself with separation anxiety, and it might become OCD later on. So there's a natural progression sometimes with anxiety disorders. So you could present as separation this, and then it eventually you could see obsessive compulsive disorder. So what you see in obsessive compulsive disorder is this recurrent thoughts that bother this child so much, and it's so repetitive that they have to do an action to get rid of that thought. And in children, actually, to diagnose OCD, you don't really need the compulsive behavior, even if you just have a lot of obsessional thinking, but it is impairing. The main operative word that we always talk about is persistent, pervasive, all across, and impairing their functioning. And functioning in children is seen in the home situation, at school, and any other place, but it has to be pervasive. So people think that OCD, I think the most common fear in the US is really contamination fears of germs. And this day and age with all those viruses around, we are, in a heightened state of alert. But a lot of times, these kids, there might have been something that happened to them, and then it just takes on a life of its own, and it becomes so intense and severe that the child is functioning is impaired. So we're talking about hand washing, not just with the typical meals, but above and beyond. So we're looking at 10, 20 times, to the point that they can't go out and complete their homework because they're so obsessed about doing that action to get rid, and all because they want to get rid of that. And they know that it's not, that they shouldn't be having it. So it's such an internal conflict.
So they have a hyper-focus on
Mm-hmm.
an anxiety issue, which then creates a behavior that even makes that anxiety worse.
Right, right.
And they become unable to direct that energy outside of that habit or that obsession, that
Right.
thought process, and they stop being able to do what is normal for them.
Exactly.
What age do you start to see that kind of manifestation?
I have seen kids as young as, I think, 6 to 7. You can even see as early as that. But what is interesting about OCD is there are so many various types. Like I said, we think that it's contamination fears. But if you look at the checklists that are available for assessing OCD, actually the commonest one that I see in teenagers is this thing called aggressive obsessions. Aggressive or sexual obsessions, that's your basic kind of fears, that you're going to harm somebody or hurt somebody. And it's so much in their thought, and you see teenagers, they have that inbuilt way of managing their symptoms. So it could be that they're watching the media violence or something, but it stays on in their mind. So what you watch really, you have to monitor, just because the aggressive obsessions can take a life again of its own.
So we're hearing a lot of complicated things here.
Right. Mm-hmm.
We know that our media is so accessible between video games and the violence and other threats that might be there. Certainly our media telling us that people are blowing themselves up all over the place, and you might be near one, and who knows what's going to happen next, whether a oil slick, a car crash, a flood, all these kinds of things. It's hard to be sophisticated enough in your emotional integrity to be able to not be frightened by it all.
Absolutely.
Right.
And of course, if you're someone who, as an adult, models an anxious behavior, it likely would be magnified in your child. When I think of anxiety, and there's so much more we could talk about with anxiety, and actually, I will say, I want to talk a little bit about what we do with a child in this situation, because I know anxiety sort of grows into depression. And I want you to give us that sort of natural progression with a teenager, let's say, someone who's very anxious, very quiet, going through that adolescent evolution of self-awareness, not really sure who they are, doesn't really have the internal intellectual or emotional skills to communicate their feelings. But they're very nervous about expressing themselves in front of their peers, certainly in front of their parents. They are anxious about school. They're getting tummy aches. They're getting headaches. They really don't want to go to school. Their grades are starting to fall because they're so anxious and focused on that. Give us a little perspective on what's going on there and how that can evolve into depression and those kinds of things.
So when you have anxiety, it doesn't matter whichever type, they have found that the most common comorbid means that you have another additional condition going on. And like you said, the most common comorbidity that happens along with anxiety, another condition that happens is depression, actually major depression. So if you look at the incidence, it's pretty high. They say 60 to 70% of kids with anxiety progresses to depression, major depression. And the reason we worry about treating anxiety is really the natural progression to major depression, because that can kill. The major depression can kill. Anxiety, you do worry. It feels like they're going to die, but they might not die. But depression kills, and that's why we act so quickly on picking up anxiety, because you could have taken care of it so much earlier
Right.
before it progresses to major depression and suicide.
So when they come in, who decides and who sees, let's say, an adolescent who comes in with significant anxiety disorder, is quiet, is starting to refuse to go to school, has somatic symptoms? Where do they enter into the system?
We have a whole triage system. It starts with that initial phone call. And based on the screening that we do over the phone with the parents, generally the parent or the pediatrician that will call, we get enough information to determine whether or not it needs, this can be resolved in our outpatient clinic through maybe some individual therapy or some work with one of our physicians. If they meet certain criteria, then it goes in another direction. And then that child would come in for a full mental health and substance use disorder assessment, an intake, what we call an intake. which is an hour and a half to 2 hour assessment. It's very comprehensive. And during that time, we meet with the child and the family. The families are always required to be involved in treatment at Keller. We really believe that's part of our philosophical underpinnings. If they're not going to be there from the beginning through the course and at the end, it's really really not going to be effective. And so, once we determine what's going on with the child, and we're generally pretty on target, about 75% of those intakes convert into some sort of a recommendation for that level of care. Then we decide, do they need to be in partial hospitalization? Do they need to be in IOP? And the discriminating factor there is how are they functioning in school? If they're going to school and they're doing relatively well at school and in the community, but yet they still have some significant needs, then an after-school intervention can be effective. If the child is unable to go to school, they are not functioning, or they're choosing not to go to school, that clearly is an indication. If another indication would be they need a medication regimen review or change, and we want them close while they're doing that so that we can assess that. But it's all done at the front end, and those decisions are made under the supervision of the physicians, and then we move forward with the course of treatment.
So I'm getting a sense of a continuum, and of course I see it from the baby point of view. I see moms who come in, and I screen them at the first month for postpartum depression.
Sure.
And I discovered that a lot of them have had clinical depression and been on medication through their young adult and adult years. And then during pregnancy, they had some despondency. They were afraid to take medication.
Yes.
They were depressed at times, and they have a baby. And naturally, the hormonal as well as the psychological issues there, the stress, the distress. You have a baby who's up all night, and you're having a real hard time coping yourself. I see a number of them are depressed. And you say there's a biological basis for these kinds of conditions.
Sure.
And a baby may really be just set up for that outcome. Do we find that depressed moms have an impact like that on babies?
Yes, I mean, two things, right? One is you can just inherit depression, that's one. And the other is how does a depressed mom parent a child, and that's where we get into attachment, Attachment issues are big. Attachment issues, basically what is attachment? It's a dynamic interaction that happens between, it is affectionate and it is caring, but it is dynamic interaction between the child and the parent. And and usually it is between 0 to 6 months of age. That's a crucial period, but it continues up until, early infancy. So yes, it does affect how the child perceives the world, and we do, which is why we believe so much in family therapy, Even if we see an adolescent, the history that we get about that early years is key to our formulation, We, per DSM, we might call it major depressive disorder or a generalized anxiety disorder. But the dynamic factors that create the symptoms is what we attempt to treat, And that is where we try to engage the family in family therapy by providing education, improving communication, which Tara does a lot of in our partial hospital program, But in our outpatient setting also, even as Dr. Thomas and I do psychiatric evaluations, this issue comes up, and that is what we attempt to address. A lot of times we will just refer them to filial therapy, which is just a parent-child therapy when the child is at a very young age. But yes, depression in parents has a significant impact on how children view the world and how they express the anxiety or depression.
And obviously can affect them growing up from there, and people get by.
Yes.
They get by, and they either can't access because they don't have good mental health support systems around, they can't afford it because it wasn't covered by their insurance, medications were expensive, they didn't have the time to commit to therapy. All those kinds of things are pretty frustrating. So most people get to the point where they're at a pretty high level of need when they finally come to you at the Keller Center, I'm sure. One of the issues, as we were saying before, they go through this continuum of anxiety, depression, on a biological basis, and they grow into young adulthood. And as that happens, and they have these burgeoning hormonal explosions, and they're interested in sex and individuality, creating some individual identity, experimenting with things that seem adult. Boy, it sure seems like a pretty easy opportunity for substance abuse and other kinds of things to take over. How do we see, well, let's say this, what are the warning signs when you have an adolescent? What are the warning signs for parents to be aware of that really warrants their trying to confront and come to terms with how to deal with behavior?
Do you want to talk about high-risk behavior?
Yeah, definitely. Well, it's, we talk about this a lot, and, parents often come to us with the question, well, are they just being a teenager, or is this something else?
Exactly.
We probably get that question several times a day. Again, one of the things we often look at is the impact on normal functioning. That's an automatic red flag if their normal daily activities are impacted. And like Dr. Fernando was saying, the risk of their behaviors. How high risk are these things that they're doing? Do teenagers experiment with things? Yes. But it does cross a line often. I think when folks come to us, we see that they have crossed a line where they could easily have compromised their life. And I think another warning sign is when parents start to feel like they've lost their control. That's a pretty good indicator, that it's time to bring your child in for an assessment.
Right.
So the child is either withdrawn, is not communicating with parents. They are socially very isolated. They are sneaking out at night. They get into legal trouble. These are all, they are not going to school as they are supposed to. The school counselor is leaving messages in the machine. These are all red flags, actually. This is beyond normal adolescence.
And frequency plays a very important role in this. How often has it happened? We actually will have parents that will come in with their 17-year-old son was found with a beer, and it was the first time they've ever suspected or found, and they're panicked. Does he have a problem? And so you look at what's the behavior. Whenever you're assessing behavior, you look at what is the behavior and how far out of the realm of normalcy is that. What's the frequency of that behavior? That if it's an inappropriate behavior, and then what's the consequence, and have they suffered consequences from that behavior, and how severe have those consequences been, and what has the reaction been to the consequence? And so I think when we go through that kind of assessment, regardless of what the behavior is, whether it's substance use, whether it's oppositional behavior, aggression, whatever it is, we can use that formula and then determine from that, is this really something within the realm of your family that is out of the normal realm? Because our families in this area with such a wonderfully celebrated, diverse community, we have to look at what's going on culturally in that home. What is the norm for that home? And what might be normal in your home or my home might be very different than what's acceptable in another, or vice versa. And so I think it's part of what we have to do is sort of help the families sort through that. What is within that realm of normalcy? Where does this behavior fall?
So I'm looking at a child who is in a setting where there is some predisposition genetically The environment has added to it, but it has not responded in a way that's looked for help. They've accepted some abnormal behaviors and difficulties along the way, separation issues that were exaggerated. But somehow they get through, they get into adolescence. The child is starting to develop significant anxiety, feeling uncomfortable about social relationships, not doing as well in school. Parents are demanding, expecting more. Then they start getting into alcohol as they go through these experimental changes in adolescence, drugs, whatever they might be. I mean, we're seeing a remarkable frequency of kids experimenting at a very young age. I mean, when we have what they call the Behavior Youth Risk Survey or whatever, where they actually do give questionnaires to kids. They used to do this regularly in Fairfax County. I think that parents objected because they thought it might actually inspire children to do things rather than give us an accurate assessment as to what they're doing. But when we did do them, we found that kids in 6th grade, 20% had tried marijuana. You're looking at kids in junior high school drinking alcohol once a month at the tune of 30 to 40%. You're talking about high schoolers who are experimenting with sex and substances of significant nature at very high frequencies, and we're all kind of hoping it's not happening. And as these kids slide into the substance abuse, you know, as you were saying, you'll see some fall off in their grades, significant change in their behavior and their ability to interact with you, their willingness to talk with you and to participate in family events. And those are certainly red flags. And when you approach them, they're in total denial. They will push you away, even if they're dying inside for some help. And then there are some who start to respond to you with, well, if you don't like me, I'm going to kill myself. Or if you won't let me do that, I might as well die. And we start to see suicide in adolescence. I guess really from the age of 15 to 24, it's the third leading cause of death. Somewhere close to 15% of kids who die at that age will have done it at their own accord through suicide. And for all those who are successful, there are probably 10 or 15 who weren't. Tell us a little bit about how that mood evolves into something as significant as suicidal thoughts.
Right, so the crucial point was to catch it earlier. Say we have missed that and it has gone on to clinical depression. Clinical depression is, again, the operative word is persistent, affecting through school or home. And people might pick up all these symptoms, the warning signs we just discussed. But one of the crucial symptoms of clinical depression is suicidal thoughts. What is interesting enough is that you don't have to have suicidal thoughts to diagnose major depression. But once it reaches that point, we are very quick to maintain safety. And safety assessment is done by like a risk ratio of seeing what are the risk factors. Because we can't really predict accurately whether it's violence or suicide, whether this person will. But what we do is like a risk assessment of what are the factors that stack up to make this person suicidal, or will the likelihood that the person will act on the suicidal thoughts. Because one of the surveys in the high school students, they found at least 15% at some point in their life had suicidal thoughts. The question is, did it go away quickly from their mind or did it stay? And if it stays, plus you have all these symptoms, other symptoms going on, that's high risk. So the minute you look at a child who has suicidal thought, I would say you have to assess what level of care would they need. It's highly unlikely to manage suicidal thoughts as an outpatient. So we do a risk assessment. So if I met a child in my psychiatric assessment, a lot of times they come in and the parents don't know this child is having these thoughts. We ask them that question. Asking them that question does not put those thoughts in their mind. They will tell me about the times that they have thought about it. And as we assess the risk, what I check for is there are certain things which increase the risk. For example, they say substance use. If you have substance use, alcohol use, that increases the chance of risk. Prior family history of suicide is very crucial in checking. Has anybody in the family used suicide as a way of ending life or getting out of a situation? that is high risk in a teenager or any child. Then we look at any stressful events. And one of the commonest things that we have seen in the ear is overdose, because it was like a breakup of a romantic relationship, as simple as that. They just felt so hopeless that suicide was the only way out. But fortunately, if you're able to, obviously if the parent has picked up on the overdose or something, we can definitely help that child. That's why it's so crucial to, even I think as a pediatrician, you might screen for that if you see these warning signs. So suicide in and of itself needs intensive evaluation, and level of care is what we assess. Hospitalization is it's 24-hour supervision, safest place. Our medications take a while to have effect, so you have to keep the child safe. And then we do actually see kids with suicidal thoughts at the partial level, depending again on the frequency of thoughts, the intensity of thought. If there is a plan or there's no plan, these are two important things that we look. Organized plan, that you say, what did you think of when you thought of wanting to die? What are the different ways you thought about it? So asking them more detailed rather than being afraid that you're putting these thoughts in your mind is really crucial.
Yeah, if somebody's not inclined to commit suicide, you can get them to do it by talking about it.
Absolutely.
But the question I have really is when I think of a parent who's worried. You're crying at times, you're despondent, you won't talk to me. A lot of times it's really because they don't know what's causing their feelings, and there are little things that upset them, but you wouldn't understand. You're my parents. And I don't want to share it with you. And there are things that are private to me, and I'm afraid you're going to think badly of me if I tell you. What can a parent do in that situation? Are there questions that they can ask, ways they can approach it?
Certainly, and I think your question, about the mood evolving to that point. I think what's important to remember is that it's not always a depression that evolves to that point. It may be an impulsive statement that's made during an argument. Well, if you won't let me go out, then I'll just kill myself.
Right.
And I think for parents to remember that statement, even if it may feel manipulative, is not any less serious or important than a child who's been depressed for a long time, who may make that same statement. And so I think, for parents to take any indication or statement like that very seriously, I think to handle it as calmly as possible, to attempt to show concern and empathy, and to attempt, to initiate conversation is really important, and subsequently to get help, because, it's certainly, especially for adolescents, it's a lot easier for them to open up to a third party, than it is to their parents.
But it's important as a parent to let them know that you're aware and that you care.
Right.
And that you want to help.
Because if a child doesn't feel as though their parent has attended to these signs or these statements, it often amplifies. And so even if they don't give you any feedback or any information, that reaching out and acknowledgement speaks volumes to the child, and really, I think improves their prognosis.
And even with the substance abuse, you're looking at situations, as we were saying, there are so many possibilities, and likely there are lots of contributory factors. But when their school performance falls down, they seem to be isolated, separated, have a group of friends that you look at and you say, well, they must be substance abusers. Yet why would you suspect your child is too? You certainly have to ask that question, and you have to hope that they have the sense to understand why you care and how it impacts them. When you get kids into your work, into your care, obviously there are different ages and different types of therapies, and we talked a little bit, you talked about cognitive behavioral therapy, where you work with them to help them understand what it is that stimulates the feelings or creates the problems for them, and how to sort of change the way they respond to those stimuli. Sure. You've talked about family therapy and training parents to help them understand how to take care of the problems as they present, and not to react to them in the way that does confuse or create more problems for the child. You've talked a little bit, you alluded to some of the social therapies that you use where you have kids working with kids so that they can understand where those feelings come from as well. But medications, you were talking about medications, they seem to be a fairly significant mainstay of really some of the long-term care. And I think people are terribly afraid of medications. In particular, we had a few years ago a scare about suicide and using antidepressants. And they're pretty commonly used. Give us some perspective on what ages you might use those medicines and really what the true worries about those medicines might be.
So if you look at the medications which are FDA approved, and we try to, most parents and everybody wants to stick with the FDA approved medication, there's only 2 medications which are FDA approved in children at this point. One is Prozac and the other one is Lexapro. Lexapro is approved, Prozac is approved from age 6 onwards. Lexapro just recently got an indication for major depression, and it's used from 12 onwards. That's just because studies have probably not been done. When we look at our medications, is there proof FDA won't approve unless it's effective? What we see, the response rate of our medications is that its response rate is 50 to 60%. A lot of parents come and say, when I tell them our response rate of our medications is 50 to 60%, they're shocked. I was shocked when I came into child psychiatry or psychiatry and said, what? Our medications work only 60% to 70% is the best response rate. That to Prozac, nothing else has met that. It's shocking, but the brain is not just all chemicals. There's so much of learning and resilience that you can learn. So that's where the combination of therapy, learning ways to cope with stress, manage anxiety, and the combination with the medication gives that complete response.
Is there a risk of suicide when you
yes.
use those?
So when you, what we see is that the response rate is 60 to 70%. Now, what they have seen, I think in 2003 or 4 was when the warnings came out about antidepressants and suicidal risk. What is interesting is that in the studies that they did not have any completed suicides. Completed suicides means deaths that have occurred.
Sure.
What they were monitoring was suicidal thoughts. So there are different hypotheses around now wondering about, is this risk truly a risk? Because I think after the medication, the warning, FDA warning came out, a lot of pediatricians, a lot of people just stopped prescribing a lot of these antidepressants. And I think the only way to look back and see what happened to the trend with the suicidal thoughts, if you look at the graph of suicide attempts actually, from 1930s onwards right up till 2010. Actually, CDC has a graph out there, and I would ask you all to look at it. The suicide rates were really increasing a whole lot, until Prozac and around 70s, 80s, there was this, 85. It started decreasing. You could see clearly that it started decreasing. Now I can't say that's directly related to it, but it's interesting to note. And it started decreasing a little bit, and then around 2003-4, surprisingly, there's a blip up. Again, I cannot say that, but it's interesting to note that the risk have, because a lot of times people have just stopped prescribing a lot of the medications, and we see that because we have patients who come back and tell me, I'm worried about the suicidal risk. How risky is that? Now the hypothesis that is that we are struggling with just as you're concerned, is what are the causes why a child could have suicidal thoughts after starting the medication? The natural thought is, could it be a natural progression of an illness? 15% of suicide in any person with major depression or clinical depression. Is it that we're just seeing that the person has started the medication and now they're energized to act on the plan that they had? That's one hypothesis that they had.
I think that it's a clear issue that parents have to trust the doctor and have to understand the risks and have to be involved in that care to monitor how that child does, and you have to bring those children back. And certainly, there's so much we could talk about. We have a great center here in the Keller Center for mental health care in ways that you cannot access anywhere else in the county. So I thank you all for being with us. You did a great job telling us about some of these issues. And I thank you for joining us. And of course, as always, until the next time, I'm Dr. Russell Libby, looking out for your health.
Dear Keller Center, I wanted to share with you what it was like for a 10-year-old boy to come to the Keller Center for help.
Dear Keller, I can't even begin to describe what it was like before we found out about your treatment program.
It was so discouraging, and every evening was a battle of wills, with Scott hating school, throwing temper tantrums.
The moment I spoke with the intake worker at Keller Center, I knew that this was the place for us.
We trust the people that we're working with, and we know that they care about our family and our son.
When you're sick, you feel vulnerable a lot, and here it's like everyone's equal, and you can be yourself, and you don't have to be worried.
INOVA Kellar Center is a not-for-profit, community-based mental health program that offers an integrated array of services. Its core programs include a day treatment program, an intensive outpatient program, a substance abuse program, an outpatient clinic, and a therapeutic day school that provides special education. Keller's focus is on families, and care is provided regardless of an ability to pay. And siblings actively participate in programs and services. And because INOVA Kellar Center provides a wide range of services under one roof, care is enhanced and streamlined, allowing a child and family to seamlessly access the programs they need.
Now I can talk to somebody, I can call a friend. It's much better than it was 2 years ago. I got that true guidance here.
Our daughter just finished her sophomore year in college with straight A's.
As a mother with a broken heart, Keller School has glued my heart back together.
Thank you, Keller Center.
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 Thanks, Keller Center.
Thank you, Keller Center.
Thanks, Keller.